Okay, good afternoon and welcome to the Davies Use Case webinar being presented by Ochsner Health System on opioid stewardship. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the manager of quality and patient safety here at HIMSS, and it is my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar, and that's Dr. Todd Burstein. Dr. Burstein, I will turn the presentation over to you as I switch out these slides here. And you can start when you are ready.
Sounds great. Thank you, Arnold. I very much appreciate the opportunity to speak to you all today. I'd like to acknowledge a few of my co-workers who were integral in developing opioid stewardship here at Ochsner. Deb Simonson, who's our VP for Pharmacy, and Dr. Richard Guthrie, who's our Chief Quality Officer, who represented the executive sponsor for this group. When we've all heard about the opioid crisis and the opioidemic, and I think a picture says 1,000 words, and you can see what has happened over the course of the past 10 or 15 years here in the United States with the growth in the number of overdose admission rates, especially with non-heroin overdose admission rates. One of the things that's interesting to point out on this slide is that even back in 2002, Louisiana was still in the red zone there. And so we've known about this and been struggling with this problem for quite a long time. But in fact, the problem has been getting worse over the last 5 years or so, and you can see in Louisiana the number of opioid-related overdose deaths has skyrocketed. And you can see that in the graph below of the United States that really this is a significant problem throughout the U.S., but especially in the Gulf South and in the Midwest areas, the Rust Belt areas, that this is a particular problem where the number of prescriptions per person actually exceeds 1 prescription per person per year. In Louisiana, we have the 6th highest prescription rate per patient in the U.S. We've seen a 380% increase in our neonatal abstinence syndrome over the last decade. And in fact, in New Orleans Parish alone, the number of deaths from overdose in 2016 exceeded the number of deaths from homicide. So this has been a particular issue across the U.S. and especially for us here in New Orleans. At Ochsner in particular, we've seen a slow and steady rise in our opioid prescriptions, and in our values and our mission and our vision are really guided us to help tackle this problem. So we believe very much in putting patients first, in innovating, serving, and healing for our patients, and being the leader to change our patients' lives. And so tackling the opioid crisis has been at the forefront of what we've been working on. Our overall strategy was first to build a governance structure around this, and then to begin educating both patients and providers about the issues around opioid use. We then attempted to provide some analytic feedback to key target areas, and from that developed best practices into our EPIC electronic health record, both hardwiring workflows and intelligent decision support. We then worked with our community to develop further resources and then reporting back on the success of our intervention to promote increased interest and dedication to this project. Our Ochsner Steward team was led by Deb Simonson. We had a core group committee at this opioid stewardship committee level, and then 8 subsequent committees underneath that all reported on a regular basis and met on a regular basis to provide input and feedback about how the various programs that we were developing were going on. We began this process by kicking up the volume on this by creating a CME conference in September of 2016, where we talked extensively to our providers about the issues with the opioid epidemic. From that, we began the process of education. So we had these posters posted in our emergency room as well as in our primary care clinics, educating both our providers and our patients about opioid alternatives and some of the dangers associated with prescription opioid usage. We then began a reporting process where we looked at number of prescriptions that are being prescribed for opioids in our emergency rooms. We began this in a blinded fashion, but then we unblinded the data and started to show each individual provider compared to other providers at their location what their opioid prescription rate usage was. This, in combination with our kickoff project, led to a significant decline in the number of prescriptions per day, initially over 40%, and to date we've had over a 70% decline in the number of opioid prescriptions being written out of our emergency rooms. We established guidelines for appropriate use of opioids and prescribing of opioids in the emergency room to limit those prescriptions to 3-day supply. With the initiative and the normative reporting on this, we saw a jump from 50% alignment to over 80% alignment with these guidelines. Similarly, it wasn't just that they were writing less prescriptions with more tablets per prescription. We actually saw a decrease in the dosing strength of the prescriptions being written. So you can see in red here, the average milliliter equivalent per prescription declined as well. There was concern that among the ED physicians that if they prescribed less opioids that they would have patients who would be upset at them, and that would reflect negatively on their patient satisfaction scores. And in fact, what we saw there was no association whatsoever. So if you look at the x-axis here, you can see prescription rates as percentages, and on the y-axis patient satisfaction scores, and there was no correlation between patient satisfaction scores and the amount of opioids being prescribed. After our success in the emergency room, we began to look at other areas where we could impact opioid usage. And one of those was on our discharge order sets for patients leaving the hospital after certain surgical procedures, especially our obstetric procedures, including C-sections and hysterectomies. And so we altered the order sets to make sure that those order sets had reduced number of days and reduced amounts of narcotic prescriptions. With the education program among our obstetricians and gynecologists, we saw an increase in the compliance and adherence to this recommended guideline, again, as well as a drop in the number of milliequivalents of morphine equivalents per prescription. But we realized that the opioid crisis began with a swinging of the pendulum from not prescribing any opioids to pain being the 5th vital sign in us over-prescribing opioids. And we didn't want to go back to the way things were before, where simply the answer was not to prescribe any opioids. We wanted to arrive in a happy medium where we were prescribing opioids safely and appropriately to the patients that needed them, and monitoring that on an ongoing basis. And so it was not about just less prescribing, but about better prescribing. That involved us being able to identify low-risk patients from high-risk patients. We wanted to say, what did the literature say in being able to answer that question? How can we design a way to monitor our patients taking opioids and hardwire that into our electronic record, and finally monitor those results and provide feedback to our providers? So the first question was about, can we identify who is at risk for misusing narcotics? And so we turned to the literature and found a study out of the University of Utah in pain medicine detailing a questionnaire tool called the Opioid Risk Tool. This tool was very effective at being able to identify patients who might be at risk for misusing opioids. If you had a low risk score in the opioid risk tool questionnaire, you only had a 5.6% risk of misusing opioids versus a 90% risk if you had a high risk score on the opioid risk tool questionnaire. This had an R value of 0.82 for males and 0.85 for females, and we thought was a good differentiator for assessing risk. And so what we did is we built that opioid risk tool into our electronic health record as a questionnaire as part of our opioid management tool. We wanted to minimize the amount of work that the physicians and nurses had to do to fill out the questionnaire, so part of the questionnaire is auto-filled out based upon other data inside the electronic health record. We use information on the patient's problem list to update the personal history section. We use information on the patient's family history to update their family history, and we use information about their social history, again, to update their things like alcohol and illegal drug usage. We also realized that this data was auto-calculated, and it's going to generate a score that may not be reviewed because the prescriber did not actually go to this section and review each individual questionnaire. And so when the score is calculated, if it's just auto-calculated, it's written out as being non-validated, whereas if the provider comes into this section and answers all the questions, then the score is reported as validated. More than just putting the opioid risk tool, we wanted to put some resources in as well. And so we wanted to explain what is the opioid risk tool, what does the scoring system look like, as well as resource information about what folks can do for risk mitigation, what folks can do as far as printing out paying contracts and other practice resources. And so we put the links to all of that inside our opioid risk tool. In addition, we realize it's more than just prescribing the opioid medication that we need to track. We need to see how they're responding as far as their pain management, as well as some of their mental health issues that are seen in the PHQ-4 depression screen. And so we built the PEG-3 analysis, which looks at pain management, as well as the PHQ-4, into our opioid management tool. And folks can now answer those questionnaires right inside the opioid tool. And they can track the responses of those questionnaires over time. So with flow sheets, we can see changes in the PHQ-4 score and see whether or not things are improving, staying the same, or worsening. More than just generating a score, we wanted to alert providers and nurses as well to what the results of that opioid risk tool were saying. And so if a patient has a moderate or high risk for opioid abuse, a banner was now going to display in the patient's chart. And when when the providers are going to the opioid monitoring section to look at that banner again will give them some information. And even inside the actual prescription for the narcotic, the opioid risk tool score and whether or not it's validated will display right inside the prescription, as well as the morphine equivalency for the provider to review. In addition, we wanted for the providers to take actions based upon the results of the opioid risk tool scoring system. And so we created BPAs that fire in specific settings that allow providers to refer patients to opioid abuse centers and some of our treatment programs to help with patients as well. And we created a smart phrase that allows them to link that opioid risk tool into their notes to help augment some of their documentation. It became clear that not all providers understood the potencies of the different narcotics that they were prescribing. And so from this, we developed a morphine equivalent daily dose calculator. This looks at all narcotics that a patient is on and calculates the morphine equivalent daily dose. There's some nuances to this in that if a medication is prescribed as an as-needed basis, how do you know what the total daily dose is? For our assumption purposes, we assumed if the medication was being prescribed PRN, that the medication was being taken on every dose that it was available to be taken on. So for example, if the morphine was written to be taken Q6 PRN, we assume that the patient was taking it Q6 to give a maximum morphine equivalent daily dose. There's also a lot of complexities about the morphine equivalent daily dose in patients on methadone. Patients who have been on methadone for a period of time will have varying degrees of metabolic rate, they'll have different rates of metabolism for methadone, which will affect its potency. And so when you put in when the patient is on methadone on their list, you'll see a range of morphine equivalents for that patient. We then wanted to assess what we can do to try and minimize the risk for our patients on chronic opioid use. So we first had to identify what we were going to do to try and separate automatically acute from chronic users, what we could do to minimize the risk for those patients by prescribing naloxone and having the providers evaluate their opioid risk using our opioid risk tool. We wanted to monitor compliance with the opioid therapy by checking urine drug screens. And we wanted to communicate our expectations about opioid use with our patients by having them sign pain contracts. And we wanted to do this all using a tool that our end providers were very familiar with, and so we chose the health maintenance activity. We built in a rule that assessed whether a patient is an acute user or a chronic user based on the fact of whether or not they had 3 active prescriptions for opioid medications in the last 4 months. We put this rule in place because if we had used an active prescription in 3 of the last 3 months, if a patient, for example, had gotten a prescription on the 30th of a month, did not get any medication the whole next month, and got the new refill on the 1st or 2nd of the following month, there would be a gap month, and then the patient would fall off the list. Using this 3 out of 4 rule allowed us to prevent patients from falling off the list who were chronic users. We initially looked at patients between the ages of 18 and 80, but we got some feedback from our providers and have eliminated the upper age limit on this. So the health maintenance applies to all patients over the age of 18, those not on hospice care, those without an active diagnosis of cancer. If you have a diagnosis of a history of cancer, you still show up on this list. And then based upon this, the chronic users were risk stratified into low, medium, or high-risk groups. To be in the low-risk group, you could not have a history of substance abuse, your morphine equivalent daily dose had to be less than 90, and you had to not be on chronic benzodiazepines. In addition, you had to have an opioid risk tool score of low. The medium-risk patients were similar to the low-risk patients, except they had an opioid risk tool of medium. And the high-risk group had either an opioid risk tool score of high or had a history of substance abuse, were on more than 90 milliequivalents of morphine, or were concomitantly using benzodiazepines. We then sent out sample lists to our end providers to verify and confirm the accuracy of this tool in identifying our chronic opioid patients. Once we had done that, we wanted to communicate what we were doing with our patients, and so all our chronic opioid patients were sent out a bulk letter letting them know we were going to begin health maintenance activities to monitor their urine drug screen, pain contracts, provide them with a naloxone prescription for these patients in an effort to provide better and safer care for them. Let's look at the breakdown of these chronic opioid users that we identified. So in the group, we actually saw that the vast majority of patients were in the low-risk group. 5,700 versus 500 in the medium-risk group and 1,800 in the high-risk group. Interestingly enough, our total of 8,000 chronic opioid users, as of our current data as of today, has already dropped to 7,700. So we've had 300 of our chronic opioid patients being able to come off of chronic opioids since the project went into place last year. We typically think of chronic opioid use and abuse as a younger age persons, but that's not what the data showed. In fact, the majority of our patients were over the age of 50 years old who were using chronic opioid therapy. When we typically think of the diagnoses that the patient has, common things like back pain do show up in a very high prevalence, but only at 35%. And in fact, only 72% of our patients even had a pain diagnosis on their problem list. Some of that speaks to documentation issues, but again, it's a very common thing to see a pain diagnosis in a patient who's on chronic opioid therapy. Interestingly enough, only 0.7% of our patients on chronic opioid use had a history of overdose. And only 2% had a history of neuropathic pain, which is something that we typically think of as a common reason for being on chronic opioid therapy. There was a very high incidence of depression as well as a high incidence of anxiety and a very high incidence of diabetes as well in this group. As far as what narcotic medications they were actually using, we hear a lot about oxycodone use, but actually the #1 agent used in our group of patients was hydrocodone. And we also learned that a significant percentage of these patients were on chronic benzodiazepine therapy. Over 40% had a prescription for benzodiazepines. When we looked at what we wanted to do for our different groups, the low, medium, or high-risk groups, we assigned various health maintenance topics to these patients. For the low-risk group, we simply wanted the opioid risk tool completed, and we wanted a paying contract signed for these patients. The medium-risk group had those two measures, plus yearly urine drug screens. And the high-risk group, the urine drug screen was switched every 6 months, as well as an annual prescription for naloxone therapy. We felt that patients who were on suboxone therapy, which has naloxone built in, did not need the naloxone therapy prescription prescribed for them because they had a very low risk of overdosing when they're on suboxone therapy. We also realized we wanted to give the providers the ability to add or remove patients to the self-maintenance topic on the fly. And so we created modifiers in our system that allows a provider, when they first start seeing a patient, if they know that it's a chronic opioid patient, to add them to the plan to track these items, even though they haven't received 3 months of therapy from us yet, as well as taking patients who may be excluded for various reasons off the therapy plans for monitoring this type of health maintenance. This is what the health maintenance activity looks like inside our EHR, and you can see here the urine drug screen done every 6 months on this high-risk patient, the need to have a paying contract, a yearly naloxone prescription, and in this patient the opioid risk tool was completed, and it shows the date that it was completed on. We built the ability to order the naloxone therapy and the urine drug screen, as well as the ability to print off the paying contract into our Perfect Care Overdue Health Maintenance Smart Set. So if the patient has any gap in their health maintenance, whether they need to have a mammogram or in this case a urine drug screen or a naloxone prescription, this health maintenance order set is suggested. When you open up this health maintenance set, only the things that they are due for are presented. So in this case, the naloxone therapy and the urine drug screen and the pain contract. And when I open that up, if I select the Narcan therapy, it will auto-associate the correct diagnosis of chronic continuous opioid use to the patient's visit diagnosis. This creates one-stop shopping for our providers and makes addressing these issues very easy. The pain contract, again, was integrated into that order set as well as in our opioid management tool. If you click on that link, it will display this pain contract, which will be able to be printed. When it prints with a faxed cover sheet. When the patient signs this, it's faxed to our health information management group that scan this document into our electronic health record with a specific document type of paying contract. That is auto-recognized by the system and then qualifies as completion of that health maintenance activity. All this was done just in time with the Louisiana legislature passing 3 new bills about opioid management, limiting the opioid prescription to 7 days, although we recommended 3 days in our guidelines, as well as having providers check the prescription monitoring or PMP program. Before, checking the PM program was a arduous task where folks had to log into the system on a separate website, put in the username and password, and then put in identifying information about the patient to find the patient's prescription narcotic usage record. We worked with APRIS to create a one-click drill-through. We were actually the first in the country to do this, and we then reached out to our Board of Pharmacy, both in Louisiana as well as in Mississippi for our providers practicing in Mississippi, to store in their employee health record, in our electronic health record, whether or not they had PMP access. If you do have PMP access, when you then click on the link, it actually drills through, provides the demographic information electronically through an interface to the PMP board, and then passes that information back as a report. So instead of taking about 5 minutes to log on the system, put in the patient's record, and retrieve the results come back in about 2 seconds. We've also been working on drug diversion, so we have software and algorithms in place among our Pyxis machines to identify high-risk behaviors where we think about our employees that may have potential for diverting medication, and that's become an active review process for our pharmacy group. We're also interested in trying to address pain through other modalities. So we've created a Healthy Back program, and this is one of the things that folks can be referred to automatically through a best practice alert in our electronic health record for folks on chronic opioid therapy. We also began implementing virtual reality. So if patients need to undergo a painful procedure, such as a PICC line placement or bone marrow biopsy, we give them these virtual reality goggles to distract them to try and reduce the amount of opioid therapy that they need during the procedure. We began other programs as well, including our functional restoration program, which combines both pain medicine, psychiatry, physical therapy, social worker, nutrition coaches. And again, we link to this in our electronic record through a suggested alert to try and guide patients who may benefit from this type of program. We've seen excellent results in this with a 50% drop in decrease in disability to pain, 30% improvement in sleep, and 63% improvement in patients' mood. We've begun to work on our surgical environment as well to try and reduce the opioid use. So for cases, certain cases we began opioid-free protocols where the patients get IV acetaminophen and ibuprofen instead of narcotic therapy. And we've been using regional blocks for patients who've had knee surgery or getting femoral nerve catheter infusions and preventing the need from using systemic opioid therapy. This has benefited not only from decreased exposure of patients to narcotics, but they also recover faster because they're not sedated. Their bowels recover faster because of the lack of exposure to the opioids. For patients that do need rehab therapy, we opened a new hospital in River Place this year and began offering dual diagnosis units and addiction units. And we also expanded our suboxone treatment program on the outpatient side as well. We've been partnering with behavioral health units across the state to provide these types of resources for our patients that live across the state to try and help them with their addictions that they have to opioid therapy. So what are the outcomes of all this? We're going to talk a little bit about what our prescription rates are, our registration with PMP, how a health maintenance program has worked, and where we're going for the future with this. As you can see, our ED prescription rates continue to decline. So we started at around, again, 170, and they're down now to 86 here on milliequivalents per RX. And our adherence to the guideline of 3 days of therapy is now in the upper 80% range. In obstetrics, we see the same data again, increase alignment to guidelines and decrease average morphine equivalents per prescription. And the same thing in our urgent care facilities as well. So definitely we're prescribing less narcotics, and in fact, a lot less narcotics. So if you look at all the patients that we see in the clinic, in the hospital, and in the emergency room put together, and say how many of those over the past year have gotten a prescription for an opioid at any point in time, we see an overall 3 to 3.5% drop in the number of patients that are exposed in the past 12 months to opioid therapy. That represents 26,000 fewer patients who are given an opioid prescription. Similar things are seen if we look at our office view population alone. And more strikingly, if we look at the folks who've been in our emergency rooms, we see a drop of exposure to narcotics in the past year from about 45% down to about 37, 38%. That's a significant drop. With our push to try and register our providers through the PMP and to have the ability to have drill-through access to the PMP reports, we saw growth in 2018 from 30% of our providers being registered with the PMP to almost 80% of our providers now being registered with the PMP. As far as our chronic opioid use patients, we see a significant increase in the amount of health maintenance activity that these patients are now getting related to their best practice of their care for our chronic opioid patients. So we see 24% of our patients who are at low risk have had the opioid ritual completed, 21% have had a pain contract done. If we look at our medium risk group, 64% have had the opioid ritual completed, 36% have had a pain contract, and 31% have had a urine drug screen in the past year. And in our high-risk population, 35% have had the opioid ritual completed, 24% have had a pain contract, 17% have had a urine drug screen in the last 6 months, and 15% have had an naloxone prescription. Before we started this program in October of 2017, if we looked at our chronic opioid high-risk patients, only 2% had had a naloxone prescription. So that represents an over 600% to 700% increase in the amount of naloxone therapy that's being given to these patients. Overall, across the system, we're seeing a 22% increase in the amount of urine drug screening since before we put the health maintenance activity in place, and 101% increase in the amount of naloxone prescriptions that have been written per month. But mortality is probably the most important thing that we're looking at. We're trying to prevent deaths from opioid overdose. And so if you look in our emergency rooms, one of the things that we know is if you make it to the emergency room alive, your chance of surviving an opioid overdose is significant. Where we see the most deaths are the folks that die before they reach the emergency room and come into the emergency room being coded. So if we look at the number of non-heroin OD overdoses of opioids in the emergency room and the percentage of those that survived, while in green we don't see necessarily a decrease in the number of patients showing up in the emergency room, in the dark blue here we see after we put the morphine equivalents and we put our health maintenance activities in place here in the start of Q3 of 2017, we see a sharp drop-off in the number of fatalities that we actually see. And in fact, there's been about a 75% reduction in the number of patients presenting to the emergency room who actually died in the emergency room from non-heroin opioid overdoses. We're very excited about this work and are sharing this through our publication. This was published in the Ochsner Journal, and we'll continue to do work to try and share and publish this activity. I appreciate very much sharing this slide set with you all, and happy to have anyone reach out to us with questions if they would like to implement similar programs at their institution. We believe that this is an epidemic that providers were at the center of, and we believe it's our responsibility as leaders and innovators in healthcare to provide solutions for that, and that's what we've attempted to do here at Ochsner. Thank you very much.
Thank you, Dr. Burstein, for that great presentation. Before we end our call, I wanted to remind folks where to go find other Davies use case webinar and how to apply for Davies, and that can be found posted at the HIMSS Davies Award website at hims.org/Davies. So again, thank you very much, and be talking to you soon.